The topic that was assigned to me, and I was supposed to talk yesterday, but because of some issues, the talk has been shifted to this morning. I'll be talking upon hypoglycemia and the cardiovascular events. Is there really a connection? So it's basically an open house debate, but here I'm the only debater, so I'll be talking in favor and against, and you are the judges today morning. So to begin, hypoglycemia we all know is the most feared or the most dreaded complication of managing type 2 diabetes. It is feared equally amongst the patients and the doctors. But besides that, we also know now that hypoglycemia is closely linked to cardiovascular events and cardiovascular morbidity and mortality. Before I begin, I must talk about what are the clinically types of hypoglycemia that I am talking today. First is something called pseudo-hypoglycemia, which you may also be knowing as relative hypoglycemia or the reactive hypoglycemia, where the patient feels hypoglycemic features but the documentation is missing. That is because suddenly we lower down the sugars. Then we have something called, I am not very comfortable with this pointer, like where is the pointer? Then we have something called a probable symptomatic hypoglycemia, where the patient wants to eat something good and he just does not document hypoglycemia, just goes off with the sweets. Then we have the hypoglycemic unawareness, where we have the documentation but the patient is asymptomatic still. And then the one which we really require in our clinical practice is documentation of hypoglycemia and also the patient is symptomatic. And the most dreaded is a severe hypoglycemia, where the patient needs assistance. Now, why it all happens? What are the risk factors? Of course, the first is the age of the patient and age of diabetes as well. Because with the aging of diabetes, there is a progressive decline of beta cells, and that leads to increased usage of sulfonylureas or maybe insulin in the patient group. Because now we have a whole bunch of hypoglycemic agents or the oral diabetic management where we can avoid hypoglycemia. But the only two villains that still remain are insulin and sulfonylurea. But besides that, there are a lot of comorbidities going on in our type 2 diabetes population. Most of them are old, there is a geriatric population already having one or the other complications like hypertension, there may be ischemic heart disease, there may be CVA. So with all these comorbidities, hypoglycemia tends to be more common. Just let us have a look how the sugars behave as they fall. So you will find that whenever we are in the normal limit, that's okay. But once the sugars start falling below around 82, 84, the insulin secretion stops, the beta cells stop working. And below 70, there is rise of counter-regulatory hormones. Patient becomes symptomatic around 54. There is decreased cognition and impaired behavior, and finally below 20 the patient goes into neuronal death. We have certain body defense mechanism against this hypoglycemia. We have behavioral changes and we also have the neurological changes, and that begins with the sympathoadrenal axis. We have changes from the brain causing rise in sympathetic axis leading to anxiety, tremors, palpitation. We have the acetylcholine going up leading to diaphoresis, that is sweating. Then we also have the epinephrine rush or the adrenaline rush, which leads to preserving the glucose utilization by the muscles and fat, and we have signals right to the pancreas causing shutdown of the beta cells and accelerated working at the alpha cells, that is the glucagon rising, and we have gluconeogenesis and glycogenolysis. So we have the defense mechanism as well in place. So with all this, if still the hypoglycemia overcomes the biophysiological response, the defense mechanism, the patient leads to coma, death, and what we are talking today morning is the cardiovascular complications. Now, as I already told you, with the sympathoadrenal axis in place, we also have some inflammatory markers. We have oxidative stress, we will have the plaque destabilization, we can have a risk of arrhythmias. Cardiac arrhythmias are very common with every episode of hypoglycemia, and hypoglycemia also predisposes our patients to prothrombic state. And all this always happens in the background of an old geriatric population, long-standing diabetes, already having comorbidities and pre-existing coronary artery disease. Hypoglycemia is also known to cause autonomic failure. So, it's a vicious cycle. A single episode of hypoglycemia will blunt your next response to hypoglycemia, and you will have hypoglycemic unawareness, and also that will lead to increased hypoglycemic events. So, now the house it is for you. The convict today is hypoglycemia, and you have to decide whether it's guilty or not guilty. With this background, just have a look and just remember, everything counts in totality. This single drop will not break the bucket, but the bucket is already full. Please remember. So with that, dear friends, vascular injury in diabetes is already existing right at the time of diagnosis. The vascular aging begins right from genetics, right from obesity, right from insulin resistance. Even when we have impaired glucose tolerance, the vascular risk is already double. With that, what is hypoglycemia doing? Hypoglycemia is also causing abnormal cardiac repolarization, leading to prolongation of the QT interval. There is reduced myocardial perfusion causing ischemic changes. There is destabilization of the atherogenic plaques, and also there is increased platelet adhesion, that is the prothrombotic states. So every time there is hypoglycemia, there is a damage to the heart. Every time the patient has a single episode of hypoglycemia, there are cardiac repolarization changes. There is prolongation of the QT interval, there is alteration in the T wave. And why do we fear the nocturnal hypoglycemia the most? Maybe because of the imbalance of the sympathetic and the parasympathetic axis, which happens only during the night when the sympathetic axis is blunted. So, a heart which is already damaged, vascular damage is already there. We are hitting it with another acute episode of hypoglycemia. Result, by the time we have aged diabetes, aged patient, we also have a built-up burden of hypoglycemic damages. So every time we have one hypoglycemia, we are also building up our bad metabolic memory. So if you look at the larger studies, you will find that the mortality is increased with every single episode of severe hypoglycemia. The non-severe may not affect much, but the severe hypoglycemia, every episode leads to increased mortality. Looking at the three major trials, the ACCORD, ADVANCE and the VADT, we find that yes, all the three studies, the intensive arm had higher incidence of hypoglycemia, and every episode of hypoglycemia was related to increased evidence of mortality, and that is why the ACCORD was aborted much earlier than it was destined to. So these are all data which are showing you that there is not much of the cardiovascular benefit if you go for intense control, but there is definitely an increased risk of mortality and morbidity with a very tight glycemic control. Now look at this graph. The HbA1c is beautiful, but even this patient is at higher risk of mortality because the very well talked glycemic variability. The glycemic variability has an inbuilt component of hypoglycemia. So every hypoglycemia, you are subjecting your patient to an increased risk of mortality. So just a good HbA1c does not ensure a good heart. Can you see this R peak? Every nadir of blood glucose corresponds to the peak of R. This R is the repolarization point, and after this the hypoglycemia improves, but for quite some time the patient remains in a stunned state, a cardiac stunned state. So the clinical implications, every episode of hypoglycemia, there is prolongation of QT interval, there is some myocardial damage, and we are subjecting our patients to an increased risk of cardiovascular diseases. Now, if you look at this like this, you hammer a strong wall, maybe it is not damaged, but now what? Do it again and it will break. Similarly, a stronger wall, if you repeatedly hammer it or use a stronger hammer, that too would break. So, my dear friends, let's put things in the right perspective. Hypoglycemia or the diabetes management is a double-edged sword. Where do I hold it? The idea is an intricate balance between glycemic control and the cardiovascular diseases. You have to manage and you have to maintain a right balance. So what is right? A high HbA1c is going to damage your patients just the same as a low HbA1c. So the challenge is to maintain the right value, and the right values are again individualized. You cannot go by one figure which will suit to all. Probably we are trying to keep it somewhere below 7.5 for our older patients and up to 6.5 for our younger population. So a low and a high, both HbA1c are bound to damage the myocardium. Just a quick revision of how hypoglycemia damages the heart. To begin with, there are hemodynamic changes causing increased mean blood pressure. There is increased cardiac overload. Then there are electrophysiological changes causing prolongation of the QT interval. There is hypokalemia. Then there are hematological changes causing increased platelet activation and increased blood viscosity. Now, this is one study which has shown that at every episode of hypoglycemia, a patient was put on a continuous glucose monitoring as well as on a Holter monitor, and it was picked up that every episode of hypoglycemia was matched with ECG changes, chest pain, and vis-a-vis hyperglycemic episodes are not so much a risk as of the ECG changes are concerned. So with that, what is the verdict of the house? Hypoglycemia, guilty or not? Hypoglycemia, guilty or not guilty? Guilty. So yes, hypoglycemia has been found to be a major risk factor linked to cardiovascular diseases and mortality. It is not that we are against treating diabetes. We have to manage our treatment and we have to achieve targets intelligently. Thank you so much.